all to this instruction course on structure and on assessing structural and functional progression in glaucoma. The chief instructor for this course is Dr. Ankur Sinha. Unfortunately, he is unable to make his presence physically here. So I'll be leading this instruction course. As you all know, glaucoma is a chronic progressive disease and which requires lifelong follow-up. And so it's very important that we are able to assess the progression. So in this IC, so we will first understand why assessing glaucoma progression is important. What are the clinical methods by which you can assess progression? And then what are the tools in assessing structural progression and the pitfalls while assessing structural progression. Then we'll also get an idea of the tools used for assessing functional progression and the pitfalls in them. And at the end, how to integrate the structural and functional progression into a single method for assessment of progression. So before we go into this, we will first have the keynote address by Dr. Nitin Verma, and after that we'll go into the other topics. With no further ado, we'll just start off the session. Thank you.
Thank you. To do with structure is got nothing to do with anything else but function. Uveitic glaucoma is responsible for up to 15% of visual loss in patients with uveitis. And it's more often more an elevation of intraocular pressure rather than glaucoma. And steroids are responsible for 50% of this pressure elevation. So the other thing is, of course, this often requires surgery to fix. If you look at the frequency of elevated intraocular pressure, anterior uveitis, whether acute or chronic, is responsible for 70% of pressure elevation, and steroid therapy for 50%. The posterior uveitis often doesn't have much to do on its own. The mechanisms, quite understandably, could be related to the angle, where the angle you could get angle closure or ciliary body rotation, aqueous misdirection, or it could be involvement of the angle with trabeculitis and blockage of the trabecular meshwork, and of course a steroid response. But quite often there's a bit of this and a bit of that. So when it comes to management, control of uveitis is paramount, and then the next thing to do is to determine the cause of the glaucoma. Very often the thing that gives you the answer is gonioscopy. Very underdone, underutilized, simple investigation that one needs to remember to do. But also one needs to look at the issue of ciliary body rotation, because the treatment of that is obviously not a laser PI. Medically, the pressure is to be controlled, and quite often surgery is needed. I'm not going to dwell too much on the medical management. It's fairly straightforward, and you can understand why the one thing to avoid is pilocarpine. It's really the surgery which is the key in many cases of uveitic elevation of intraocular pressure. So the indications for surgery are uncontrolled intraocular pressure, maximal medical treatment, and very rarely increased cupping and visual field loss. But most often it's an alarming rise of intraocular pressure which is uncontrolled. What are our options? We've got trabeculectomy, we've got glaucoma drainage device surgery, and in eyes with very limited visual potential, perhaps cyclodiode. One can consider things like SLT and MIGS and non-penetrating glaucoma surgery, but certainly what needs to be avoided is ALT and phacotrabeculectomy. Standard trabeculectomy has a very high failure rate. In fact, only 30% of them would succeed at 5 years. But enhanced trabeculectomy with the use of antimetabolites is, I think, the way to go. Mitomycin C is used intraoperatively. It has longer-term effects and inhibits cell growth for more than a month, and now is the standard of care for trabeculectomy. At the Sydney Eye Hospital, we use concentrations of 0.4 milligrams per mil and apply it for 1 to 3 minutes. 5-FU is used post-surgery. It's used along with phacotrabeculectomy and also at the time of cataract surgery. So Coming on to the standard mitomycin C trabeculectomy, I think I use a phonics-based flap, and really the key is to apply the sponge with mitomycin C, very often a neuropathy, for about 1 to 3 minutes in the phonics as well as on the sclera. We use a standard Kelly sponge peripheral iridectomy, and then 10 nylon for the releasable sutures for the flap, and 9 vicryl for the conjunctiva. But in all this, glaucoma surgery is the easy part. The thing that decides success is the post-operative, your post-operative, what you do post-operatively. And really, that's what decides between success or failure. The post-operative management of the post-operative course is divided into 2 phases. The first 10 days or so, where we've got to modulate flow. So if you've got a flat AC, reform it. If you've got to release a suture, release it. And then after that, you go for the next 2-3 weeks, where that's where you regulate the inflammation and flow. It's important, it doesn't matter what type of releasable suture you use, it's important to release them early. And it's best to release them one by one so you can titrate what you want to do. Sometimes it's necessary to do bleb massage. But then after about day 7, the inflammatory response starts. And that's really when you go on to the next phase of controlling bleb inflammation. Now, the Mofield's bleb grading system is a great system to use so that you can sort of try and quantify what you do. And basically around the grade 2 vascularity is when you start pumping the steroid in, 6-7 times a day, and also give a little injection of 5-FU. One can give more than one injection, but when it finally comes to a point where the bleb is encapsulated, then it's best to do an early needling with 5-FU. So while there are no prospective studies, a lot of retrospective case studies show that there's a 90% success rate at 1 year. And of course, the risk factors for failure include cataract surgery and chronic grumbling granulomatous uveitis. Coming on to glaucoma drainage devices, I don't know what is the one you use here. I believe it's the Ahmed valve and the Bearwelt valve. I tend to use the Maltino valve simply because it was invented by a friend of mine, Tony Maltino, from Dunedin in New Zealand. This is slightly different in that it does not have a valve. It's just a plate with a tube, and so you've got to tie the tube off after placing it, and the tube is covered with either pericardium or with sclera. We close the conjunctiva with 8 vicryl and actually tie the tube off for the first few weeks so that a nice capsule, a nice bleb forms around the tube, around the glaucoma drainage device plate, and so that in about 5 or 6 weeks, when the vicryl suture pops, flow starts into a preformed space. So really, you need to continue using the glaucoma medications even post-operatively. If there's any hypotony or inflammation, one needs to control that very, very well. The success rates are pretty good, 54% at 5 years. And really, about a quarter of them after 5 years would require additional treatment. But the use of mitomycin C and 5-FU in this case is not really necessary. So the tube versus trab study certainly points more towards the tube than trab. And as you would see in this case study, I had a 46-year-old patient treating for a PED. Everything was going very well, and then she developed endophthalmitis. We treated the endophthalmitis. Her vision came back after vitrectomy and lens extraction. Here are some photographs of, the disaster that endophthalmitis produces with nerve swelling, macular swelling, and everything. This is what her OCT looked like. So rather than being just a macular degeneration issue, it became a uveitis following the endophthalmitis. Tried her with oral steroids, fantastic response. Then gave her an Osidex, and then, of course, the pressure just shot up and wouldn't come down. As you can see the swing of pressure here, as well as the swelling of the optic nerve, and that's really a graph showing you how erratic everything was going. But now, after a Maltino valve, her pressures have come down, and I still have to think, now I'm going to give her, I'll need to give her another steroid injection, but hopefully the valve will be able to take care of pressure rise. On the issue of MIGS or or non-penetrating glaucoma surgery. It's sort of a changing area. A lot of people are talking about it. And the minimally invasive glaucoma surgery business, one can see that it acts in different ways. Of course, the CyPass is now off the market. People have tried to create algorithms that in this case you do this, in this case you do that. But I still remain completely unconvinced that this is a good idea in patients with uveitis, so I tend not to use it at all. So to close off, I think mitomycin C trabeculectomy is fine. When one needs to repeat such surgery, you might consider doing a tube. But in high-risk patients, I think a primary glaucoma drainage device is the way to go. So the take-home message is that you can do whatever surgery you want, but the post-op care is absolutely critical. Mitomycin C and other and 5-FU have changed things quite a bit. Tubes are being used increasingly, and again, for this thing of mention, I still don't think that MIGS and non-penetrating glaucoma surgery is a good idea in such patients. So, thank you.
Thank you, Dr. Nitin, for a wonderful presentation. So I just would like to ask you a question. So hypotony is a major issue in uveitic eyes. So how do you deal with that? What is your experience of using Ologen?
Well, I haven't used Ologen, but I think hypotony is quite often related not only to the glaucoma surgery but also to the uveitis itself. So unfortunately, you have to be pretty hard on the uveitis, and then you run the risk of glaucoma response on the other side. So it's a minefield. And that's why I'm saying it's not the physical act of surgery that matters, it is the post-op period and the lifelong continuation of monitoring for these patients. I think that's the important thing. It's not just simply, oh, I've done a trab and so it's all fine. In fact, that's sometimes the start of the problem.
Thank you. Thank you, sir. We'll start off with the instruction course. The first topic for the course is importance of establishing progression in glaucoma. And this will be by Dr. Amit Porwal.
So good afternoon, everybody, and thank you the whole team. Ankur is not well, so our chief instructor is not coming, and Dr. Suhasini is going to take over of this whole IC. So without wasting much time, I go with my presentation on what is the importance of establishing progression in glaucoma. मैं control कर देता हूँ. ठीक. So progression is a rule in glaucoma than an exception. So we all know that it's a leading cause of blindness affecting more than 70 million people. And the main goal of treatment is not only to prevent blindness, but to prevent progression of the disease from reaching a stage that adversely affects the patient's quality of life. So this is very, very important. It is not, it is a progressive disease, and we have to take into account the patient's quality of life. So why checking progression is important? The questions arising in one's mind once the diagnosis is made is whether to initiate treatment or to observe, whether to add, alter, stop the ongoing treatment, or when to have the surgical intervention. So the answer lies in determining the progression, and that's where progression is very, very important. It is closely associated with the quality of life, the daily activities like reading, driving, the mobility of the patient. These patients are more prone in advanced glaucoma for loss of balance, the risk of fall is high. They won't do their professional and personal tasks independently. So we have to target our treatment based on these daily activities of the patients. So targeting treatment related to these activities makes sense. So how do you define progression? It is defined as worsening of the structural and or functional defects. So this is very important, and or. It is essential to assess both the structure and function to detect progression. And how do we detect? We detect it with the OCT and the visual fields. It is generally accepted that its optic disc changes precede the visual field damage, but the trials like OHTS and EGPS have shown that structural and functional damage seldom overlap, and visual field changes may precede the optic disc damage. I'm not going to go into detail of the visual field checking progression on visual fields or the OCT, because my subsequent co-instructors are going to talk about it. So how do we define progression according to the AMGT trial? It says that there should be a significant change from the baseline on at least 3 visual field location on 3 consecutive visual fields. So visual field testing is usually the standard automated parameter, which remains the gold standard for measuring glaucoma progression. And OCT is also being utilized with the qualitative and quantitative analysis to assess the rate of the structural change. So there are 2 approaches whenever you use these 2 equipments. You have the event analysis and the trend analysis. And what is event analysis? It compares the baseline measurements to the future follow-up measurements to define whether that measurement is significantly worse or no to the previous one. trend analysis, it uses the serial measurements to determine rate of progression. So what is more important for us is to determine the rate of progression so that our treatment can be targeted, which I'm going to talk in my subsequent slides. So the risk factors which we have to take into consideration is the visual field status, the optic disc appearance, the IOP level of the patient, and again the adherence to and persistence with the prescribed therapy, what is the medical, family and social history, and the constancy of these factors over the extended period of follow-ups. So rate of progression is not only important to determine the progression in glaucoma, but it is critical to estimate the rate of progression to determine how aggressively we have to treat the patient. So rate of progression plays a very important role when you want to report progression. So the most treated eyes do not progress at rates that lead to future visual impairment. But there is a proportion of patients which do progress, and we have to take care of that by measuring or checking for progression. And how do we check for progression, which I've already mentioned? There are something called a fast rate of progression, which are generally problematic. But this slower rate of progression also can be problematic if it is especially seen in young patients, and particularly in a young patient who is diagnosed with a late disease. So in this patient, even the slow progression is going to be very important. So when to initiate an escalate of therapy is based on the individualized progression rate-based treatment targets, the age and the life expectancy of the patient, the associated risk factors like severity of the disease and the visual-related quality of life. So what is fast progression? Basically, a fast progression, according to the literature search, is when you have a mean deviation rate of minus 1.5 to minus 2 decibels per year, and an OCT RNFL thinning rate is around 0.76 to 1.5 microns per year. So this is the visual field loss and disability. You can see that the rate of progression, as the rate of progression is more, then you can see the slope is going down, which is in red. So visual field deterioration rates in glaucoma patient, and depending on the rate of progression, the steepness of the slope, a patient may become blind or visually impaired during his or her lifetime. So these are different graphs showing the different life expectancy of the patient. You have the life expectancy of 5 years, 10 years, 15, 20, and 30 years. So it is important to incorporate severity of the disease and the life expectancy to identify clinically important rates of progression for an individual patient. So you can see in this graph, the first graph is advanced glaucoma, which is minus 12 decibel, and the second graph is minus 20 decibel visual field loss, which is legally blind. So advanced disease is defined as MD less than minus 12 decibels, and in figure B you can see that MD is less than minus 22, that represents the statutory blindness. So different life expectancy have different rate of progression, have a different slope, so we should know when to change or modify our therapy. So according to the EMGT trial, it is the magnitude of the initial IOP reduction that was a major influencing factor. Other factors of high rate of progression were high baseline IOP, exfoliation, bilateral disease, worse mean deviation, that is less than more than minus 4 decibels, older age, and frequent disc hemorrhage during follow-up. So two things which we have to look into the practices. These are all the risk factors for high rate of progression, but what we have to more concentrate on is the frequency of disc hemorrhage and exfoliation. These two are very important factors. So each higher or lower mm of IOP and on follow-up was associated with approximately 10% increase or decreased risk of progression. That's what this EMG trial says. So again, the staging and progression of the risk factors, you can see what risk factors are there for progression, what for blindness, and what is the major for what is included in all the major studies which are looked for progression in glaucoma. So the only thing what is looked for is advanced disease at the time of presentation. So all the studies have taken this into consideration, other studies have taken other factors. So what is target IOP and progression now? We have to fix up this is very important. The progression rates are highly variable among patients. Target IOP needs to be individualized with sufficient number of visual fields and known rate of progression. The target IOP should be the main factor to assess or adjust, because that is the only modifiable risk factor which we can treat. So significant progression, aim for lower target. Earlier and more aggressive treatment is needed for at-risk patients. You have less frequency risk and higher target IOP for patients with no direct risk for fast progression. So practical guidance for measuring visual field progression rate, all these guidelines are available, whether you look for EGS, APGS or GSI. They basically educate the ophthalmologist on the management of glaucoma. They emphasize not only on detection, but also to detect the rate of progression in the daily clinical practice. What is recommended is every 4 months, a visual field has to be performed for the 2 years, or at least twice a year for the next 3 years. So basically we need 6 visual fields in a period of 2 years or 3 years to look for the progression. So an estimate of progression can therefore be exploited to the patient's life expectancy, and management can then be changed if the patient is at risk of disability. So estimating a patient's initial rate of progression is very necessary. Individualized treatment approach should be taken, and when the risk of becoming visually impaired or blind during the lifetime is high, and earlier and more aggressive IOP-lowering therapy should be initiated. So what are the challenges in dealing with progression? First, there is detection. Second is determination of the rate of progression, and finally is the adjustment of the treatment tailored to the individual rate of progression. What are the other challenges? There is non-adherence and poor compliance to treatment. You might feel that IOP is, we have given therapy, patient is saying that he's compliant, but he might be non-adherent and poor compliant. There's lack of patient understanding of this disease condition. A younger patient is more dynamic and he doesn't give a damn about his health. Male gender, high frequency of dosing and low frequency of follow visits. So the goal of treatment, as I told you, is to maintain the patient's visual function and related quality of life at a sustainable cost in terms of inconvenience, side effects, and financial implications. Again, one more thing which we need to introspect. Even when progression is detected, clinicians do not assess the rate of progression. Why they don't assess? The importance of progression, the talk was because of this. We as a clinician, we don't look for the progression because of lack of expertise, because of lack of sufficient data, or we are so busy that we don't have time to look for the progression. And also there's a great discrepancy between what the practice pattern guidelines recommend and what is really followed by the practitioners. So these were a lot of literature search I did, and this is what the conclusion what the study is. So what is commonly being followed among all our specialists? The clinical judgment is followed to look for progression. That is wrong. We have to have the visual fields and now the OCT to look for the progression. What usually the clinician does is he compares the grayscale, he compares the decibel sensitivity values, global indices, total of apparent deviation plots, and of course the series of visual fields which the patient carries. But no, that's not the way to look for progression. There are progression analyses on these machines, and we should analyze this on the machine and try to find out what is the rate of progression which is going to decide everything. So this approach, what I mentioned about earlier, was subjective. It relies on clinicians' knowledge, experience, and results in variable assessments, even among glaucoma specialists. So to conclude, the key challenge in glaucoma management is differentiating between patients that are at risk of blindness and those that are not. Regular testing of the patient is required to accurately evaluate the rate of progression. And how do we evaluate the rate of progression? That we need at least 6 fields in the span of 2 to 3 years along with the OCT, and we should look for the rate of progression and not just series of fields in front of us and we try to analyze subjectively. Fine? Thank you.
Thank you, Dr. Amit, for that wonderful overview of progression. So before we go into all the functional and structural tests, we will first talk about the clinical evaluation, the clinical methods for evaluating progression of glaucoma. And this is by Dr. Digvijay Singh. Unfortunately, he is also unable to be available here. But he has sent a pre-recorded PPT, so which we would be playing now.
In this presentation, the clinical parameters we evaluate in glaucoma patients include visual acuity, eye pressures, gonioscopy assessing the angles, and looking at the optic nerve head. Parameters we evaluate in glaucoma patients include visual acuity, eye pressures, gonioscopy assessing the angles, and looking at the optic nerve head. Visual acuity is generally not a good parameter to evaluate progression because it gets affected only in the late stage of glaucoma. There is a non-linear correlation with progression. Multiple confounding factors could affect visual acuity. Therefore, it is not a good parameter to assess progression. Worsening intraocular pressure or a shift from a lower to a higher pressure could be a sign of progression of glaucoma. A previously controlled IOP becoming uncontrolled, or excessive fluctuations or IOP spikes, as can be seen in this diurnal variation chart, is also a sign that glaucoma could be progressing. Changes in the angles as seen on gonioscopy, whether it is an increasing number of peripheral anterior synechiae or increasing pigmentation, or a progressive angle closure with a narrowing of the recess, or an increase in the amount of exfoliative material, may all indicate progression of glaucoma. Probably the most definite sign for glaucoma progression are changes on the optic nerve head. An enlarging cup, development of disc hemorrhages, or increasing peripapillary atrophy all indicate towards glaucoma progression. Changes in the retinal nerve fiber layer, such as a progressive loss of RNFL, is an indication of progressing glaucoma. Tools such as the disc damage likelihood scale may be utilized to document progression. These are the stages of glaucoma as it progresses. It requires both a clinical evaluation as well as perimetry to make the correct staging. Various clinical trials, such as the early manifest glaucoma trial, the ocular hypertensive study, have looked at clinical parameters which may predict progression. These include an increasing age, a higher IOP, worse visual fields, presence of exfoliation, presence of disc hemorrhages, and many others. Once you suspect progression on your clinical examination, the next step involves documenting it structurally using the optical coherence tomography and functionally using the perimetry. Thank you for your patient listening.
We'll move on to the next talk on tools to assess progression on visual fields. This is again a pre-recorded presentation by Dr. Ankur Sinha.
Any questions?
Yeah, in the meantime, we can take questions. So before going into the fields and doing the OCT, so these are not the only methods for assessing progression. Clinically, we need to have an idea. So if the intraocular pressure is slowly rising up. Okay. You can start. I will continue later.
Each and everyone here, and I welcome you all on behalf of all my co-instructors in our instruction course on structural and functional progression in glaucoma. I am so sorry that I am not able to make it for this wonderful DreamCon 2022 because of being recently tested positive for COVID. I thank Dr. Partha Viswas and office bearers of AIS for giving us this opportunity. I'll be talking about tools for assessing progression in visual field. There are various methods to assess progression. The crudest method is the clinical assessment. Then we have event analysis in terms of guided progression analysis, glaucoma change probability. Then we have trend analysis in terms of global indices, point-wise linear regression, cluster trend analysis, and then we have got certain sophisticated approaches. So clinical assessment lacks standardization. What one does is one spreads out all the visual fields and compares the grayscale, decibel sensitivity, global indices, pattern deviation plots, and total deviation plots. The approach is pretty subjective and it is based upon the knowledge and experience of the person. Now, this is an overview analysis of a 10-2 visual fields of a patient from April 2010 to June 2021. And even on this 10-2, the patient has large blind areas. So with this 10-2, we have non-availability of GPA and VFI. So the only method left to assess progression is clinical assessment. So what we do is manually assess all the points, and we have to be very, very careful as we just have 3 lines of visual field in this patient. So there are a lot of edge points. And when we compare these April 2015 with April 2010, we can see that probably there is some amount of progression here, but we should also be aware that these edge points are subject to test-retest variability. Now, when we even suspect this progression, there's no significant change in mean deviation because the field is too depressed to be compared. We should also realize that as the field gets more and more depressed, the PSD tends to improve because there's less and less irregularity in the visual field. So overall, when we compare from 2010 to 2021, we see that the visual field area is more or less preserved with almost similar kind of sensitivities, although these last 2 fields are not very reliable, but we can say that patient is more or less stable for the last 11 years. Now we move on to event analysis. It compares the 2 baseline averages with the test in question. Now progression is identified when there is worsening present at each visual field location. Now what are the issues of event analysis? The progression cannot be identified sometimes because there is sometimes a good visual field and sometimes a bad visual field because of test-retest variability. Also, the analysis depends upon the quality of baseline visual fields. So if there's a learning curve, we have a faulty baseline visual field. Also, it cannot provide rate of progression. Guided progression analysis is a point-wise event-based analysis based upon pattern deviation. It picks up points which are outside 95% confidence interval limit of test-retest variability obtained from stable glaucoma patients. Now it needs two reliable baselines. Now if there are more than 3 locations worsening in more than 2 fields, it is called as possible progression. If there are more than 3 locations worsening in 3 visual fields, it is called as likely progression. It may also give high false positive in patients who have large test-retest variability or if there are response errors. It may also not be very effective in glaucomas, advanced glaucomas, where the depressed point values are less than 15 or less than 20 decibels. Now, this is a guided progression analysis of a patient from 2010 to 2022. And what we see that there are certain points which are marked as too depressed because the points are so depressed or so blind that they cannot be followed up even on guided progression analysis. Also, there are certain points which are seen progressively worsening on 1, 2, and 3 consecutive visual fields. They have been flagged as hollow triangles, half-filled triangles, and dark triangles. And we also see that the VFI is more or less stable till 2018, and then 2018 to 20, there is a sharp decline because of this field, which is an outlier. Also, we are aware that during the COVID times, the follow-up and drug usage have been erratic in a lot of patients. Now, glaucoma change probability was first used in early manifest glaucoma trial. It utilizes a change in more than 3 locations in 3 consecutive visual fields. Now, definitive progression is associated with a fall in mean deviation of more than 1.93 decibels, or if there is a change in more than 4.85 number of points, which is significant from the previous visual fields. Now, it also gives you these box plots, which are something like a candlestick pattern. Now, this is the best point and this is the worst point. And this box signifies the 11th best point on the top and 63rd best point on the bottom. So this is 0 to 15% and top 15% of points. And this is the median point of the visual field sensitivity. Now, this is the comparison of the box plot of a patient. We can see there is a generalized depression because the box plot has come down. Also, this tail has lengthened. So there are certain focal deficits here. And we again see in January 2011, there's slight increase in the focal defects and there's slight decrease in the mean deviation. Maybe there's slight increase in generalized depression also. So this Jan 2012 visual field is almost similar. Box plot is similar to what we see in Jan 11. And similarly, we can see that December 13 was almost similar to the past 2 visual fields, but there's slight increase in sensitivity in the better points. But what we see in the January 15, February 15, and March 15 is there is increase in the tail, which is the local defects, localized defects, the focal defects, and also there is increase in this box plot, signifying there are more number of points being involved. So when we look at the visual field analysis on the GPA for this patient, we find that the visual fields are more or less stable till 2013, and the cause of those box plot being abnormal was this disc hemorrhage and associated nerve fiber layer defect in the inferior quadrant of the disc. Now, trend analysis is derived from linear regression or its modification in a series of visual fields. It provides change along with the rate of change. So we have the rapid progressors and slow progressors there. It assumes the change would be linear, that is fixed over a period of time, and it requires minimum of 5 to 6 visual fields. It may be applied to the global indices, the cluster of points, individual points, or it can be even event-based. Trend analysis of global indices includes the trend analysis over mean deviation, pattern standard deviation, or visual field index. Now, when we talk about mean deviation, it is the global average of differences between the patient and the age-matched normals. So we can apply a linear regression, which gives you a loss of glaucoma in terms of decibel per year, which if it is progressing, it will be negative. For similar rate of progression in the mild glaucoma, that is a loss of 3 decibels in the early glaucoma, is not similar to loss of 3 decibels in advanced glaucoma because log scale itself is a non-linear scale. Now, pattern standard deviation looks at the irregularity of the focal defects, Large PhDs may indicate presence of localized defects, but a low PhD would point towards a normal glaucoma visual field or severely diffuse visual field loss. Now, this is the glaucoma change probability, which is showing you the comparison of mean deviation, and the slope for mean deviation here is not significant. Similarly, we have this plotted pattern standard deviation, which is again seemingly not significant here. Now, trend analysis, we have another option of VFI. VFI ranges from a scale of 100 to 0, that is normal to end-stage glaucoma. With better sensitivity, the VFI includes pattern deviation plot. That is when the sensitivity is better than 20 decibels. If that pattern, if the sensitivity is less than 20 decibels, the VFI includes the total deviation plot. The VFI, which includes pattern deviation plots and the mean deviation plots, can be used as complementary in cases of we're trying to assess progression. Now, this is a VFI of a patient. So what we can see here is the VFI is more or less stable. In fact, there's some amount of learn effect, so we can sigh relief that the patient at least is non-worsening. But something happens here between 2018 and 2022. So the patient did worsen, but the slope is not very significant here. Then we have this point-wise linear regression analysis. There's longitudinal changes at individual points in the visual field locations. It estimates the slope, that is decibel per year for each location. Now, we can also do a trend analysis of clusters. So we can divide the visual field into various clusters, and we can do a regression analysis of total deviation clusters or regression of pattern standard deviation clusters. In HFA, we can divide into 10 or 20 clusters, and it has been done in various studies. Then we have certain sophisticated approaches, which includes the Bayesian analysis. Then there are machine learning classifiers. Then there is permutation of point-wise linear regression approach, and then there is answers and non-linear models. So there are various approaches which can be used to identify progression in glaucoma. Thank you for your kind attention. A very good evening to each and everyone here, and I welcome you all on.
So what we have seen now is the evaluation of the functional progression. So we will now see the pitfalls in interpretation of progression in visual fields, which will be by Dr. Shalini Mohan.
Thank you, Dr. Subhashini. Good evening, everyone. At the outset, I would thank Dr. Ankur Sinha for having me here for this IC. Now, just now we saw that how to assess the progression. Now, it is important to assess the pitfalls in progression because on the basis of that, we need to decide the treatment modality for our patients. We know that visual field progression is very important and challenging aspects of glaucoma management because it influences the critical care of our patient and also is used as an endpoint in many of the clinical trials. So, the question to house is, which is the most common method to judge progression? What you use generally, what we all use generally is that we keep all the fields of the patient in series, one after the other, and try to assess the progression, and then start Googling our eyes. So the thing is that, is it the right method? Can we actually judge progression by this method? The answer is no. Because there are two important factors which we need to consider. First and foremost is that there is a normal visual decay which happens with every individual as the age advances. So there is a kind of progression and there is depression in visual fields of around 0.07 decibels per year. Now this depression is common in glaucoma patients and it is around 0.6 decibels per year in the patients who are being treated for glaucoma. The patients who are not being treated, this mean rate of progression is around 1.1 decibels per year. Another important factor which is there is about fluctuation. That means that there is a short-term fluctuation, that can be a long-term fluctuation, and also there can be a test-retest variability which needs to be considered whenever we are actually doing the visual fields for our patients. Now, this was a study which was done on 51 subjects in which every week visual field was done for 4 weeks. And what was seen was that whenever any depressed point were near to fixation, there were more test-retest fluctuation. Now, as we can see in this graph, if the depression is around 0 decibel, the fluctuation was from +3 decibels to -7 decibels. Similarly, if fluctuations were near to -10 decibels, then the retest test variability was -1 to -16. Moreover, whenever just now we saw in the talk of Dr. Ankur also, whenever there are peripheral points which are being assessed, there is more test-retest variability. So these things needs to be considered whenever we are assessing progression. And if we don't consider these things, then we are likely to miss something important. Now, to establish a valid progression, it is important to have at least 6 visual fields in 2 years' time. Then only we can get exact rate of progression, and accordingly we can modify our treatment. So we saw just now the overview printout, which has got the grayscale, the data, the total deviation plot, and the pattern deviation plot. Now, on the basis of this, we can see that, yes, the patient is progressing. Like here, we can see there is no scotoma, but then there is a scotoma in the inferior part of the visual field, and we can see it is enlarging. But the thing is that whenever we are seeing like this, we also focus more on mean deviation. Now, here we can see the mean deviation here is -3.7, and similarly it is increasing in negative values. So, but there is no statistical analysis and we cannot detect the rate of progression. So how should we identify in such a scenario? Now, whenever there is appearance of a new defect, it is important to apply these important parameters to assess the progression. Whenever there is a cluster of 3 or more non-edge point, each of which declines by more than 5 decibels than the baseline, this is an important criteria to assess progression. Another criteria is that if there is a single non-edge point which has gone depressed by more than 10 decibels, or a cluster of 3 or more non-edge points, each of which has declined by less than 5% levels. So we know that now the new defect is there for the patient, and that means he has progressed. Now, this is important that this should be on 2 consecutive fields. Another important thing is that if there is deepening of a pre-existing defect. So when do we call it as deepening? We say that whenever a defect has enlarged by 2 or more points within or adjacent to an existing scotoma. So there should be a scotoma around which there are 2 or more points which have worsened by 10 decibels. That means that it has progressed. Now, we saw that there can be an event-based progression where event has happened. So we take 2 baseline visual fields, and from 2 baseline visual field, the particular field of the patient is compared, and whatever changes are there, that is actually given in the form of GPA printout, and that is the event-based analysis. The another one is trend-based analysis. That means we are following the patient throughout the time duration, and that is given in the form of trend-based analysis. So we realize that the most important thing in both these analyses is to establish the baseline. So what is the baseline visual field? That means patient should have 2 consecutive visual fields which should be extremely reliable. And then only we can compare from these baseline visual fields to other visual fields, and then only we can say that yes, the patient has progressed. So this is about the event-based analysis, where these are first 2 baseline visual fields and by which rest of the fields are being compared. So whenever there is a comparison, if there is a depression in one field at one point of time, this is an open triangle. If the depression is seen on 2 consecutive visual fields, this is an half open triangle. And if it is on 3 consecutive visual fields, it is a closed or the dark triangle. So now here we can see the GPA printout, and if we see this glaucoma probability map closely, these are the areas where we can see the open triangles or the closed triangles or the half triangles, and we can see the message lower down that there is a likely progression. Now, if we don't establish a proper baseline visual field, then obviously the comparison will not be proper, and then we tend to miss certain things. Now here we can see the GPA printout, and Again, a message of possible progression and likely progression. Now, this GPA printout I wanted to show, because if we see in the first printout here, we can see there is an superior arcuate scotoma, and in the next one, there is sudden depression of visual field, and almost whole of the visual field is gone. And so we examined the optic nerve head of the patient, and what we saw is that optic nerve head of the patient was not actually that progress. So what was the problem? So we explained the patient again, we made him comfortable, and then again the fields were repeated, and this was the thing what we got. So the thing is that many a times the patient is tired, the patient is fatigued, he is not able to perform as he should have been, and at that time there are likelihood of problems, and that might confuse the clinician that there is a progression, but actually that is not. Now coming to another thing, that here we can see this is a visual field of a patient in which we wanted to establish baseline. Now you can see that there are large amount of fluctuation problems in the upper part, almost 9/20, it is double flagged. So we tried to do another visual field for the patient. So it was not just one or two, we had to do series of visual field. You can see 1, 2, 3, 4 and 5. So it is not that the patient's visual fields are improving. If you see the first one and if you see the last one, how good they are looking. It is not that they were improving, but it is actually that there were so much of losses, fixation losses you can see everywhere except in the last field. So it is not that patient was improving, but actually patient was learning, because visual fields is a difficult test to perform. Even when we are performing, it is not very easy to capture each and every light what we are seeing. So it is a difficult test, and that is why many a times patient needs to be explained that yes, there is a problem. Now coming to trend-based analysis in visual field, which is another very important to assess the rate of progression which is given in trend analysis. Now if we enlarge this graph, and we see that first two are the baseline visual fields as we already established. Now if you see the next one, it is looking depressed, but another visual field is looking a bit improved. So the thing is that if we see this graph, patient is looking almost stable. But what is happening over a period of time, that is what trend-based analysis says. Now, over a period of time, you see that yes, patient is gradually and slowly progressing, and this is the rate of progression which has been given by trend analysis. So this is the problem with event-based analysis, that if you compare with just one visual field, you're likely to miss something which we can get in trend-based analysis. Now, this is another very interesting patient. If we see the baseline visual field here, these two are baseline visual field, and look how rapidly the patient started progressing. So here, and then suddenly, at here, you can see all these clusters of visual field, they are almost stable. So what has happened? Actually, when the patient started progressing so fast, then there was an intervention which was done. So surgery was done for the patient, and again the visual field, they became stable. So now in this particular patient, if we see this graph, this is progressing so fast, and it is giving an impression that this patient will become blind in due course of time. So here what should we do? We need to re-establish the baseline. Now once you have modified your treatment here, then you change your baseline visual field. Now these two visual fields are the baseline after you have modified your treatment. So you have modified here the treatment, and now look, the patient looks stable. And if you can trace this graph, patient is not there is no likelihood of patient getting blind. So sometimes you need to re-establish the baseline, and you need to change the baseline to get the exact value of progression. Can I take 1 or 2 minutes more, ma'am? Thank you. So there are other challenges also which we face while dealing with these progression. Now like in this, if you see the pupillary size was just 2 millimeter, and see how depressed the fields are looking. And when the patient was dilated with 3 to 4 millimeter size, the visual field improved. So you must look after the pupillary size also. It should be normal. Similarly, again, this is a miotic pupil, and this is a normal pupillary size. They can be problems problem with dilated pupils also. So this was a study also which was published in 2020. Now here we can see this is the dilated pupil and this is a normal pupil. So if you have done the pupillary examination with dilated pupil, that means at every examination you have to do dilated visual fields. So that is very difficult. So always try that whenever patient is coming for the visual field, the pupils should be of normal size. Now this is, I will skip that. I will move on to this. Now here we can see this particular patient that there was a increased scotoma in the patient who was regularly following with us. And then again, we explained the patient and look how it has improved. This is corresponding central defect corresponding to his cataract. So sometimes we need to give few more extra time to our patient explaining about the problem. Now here we can see now this particular patient in which this was a regular follow-up and following the patient with us, and we can see that there was a scotoma here in the superior and the inferior part of the visual field. But again, the visual field was repeated and he had this deepened scotoma. And when we look at the disc, it was looking absolutely non-glaucomatous. So in such scenario, what to do? Again, the patient was explained the procedure, it was repeated, and it improved. So now coming to another very interesting case, this was a glaucoma patient. Now we can see the right eye of the patient which was almost normal. In the left eye showed inferior scotoma and he was doing pretty well. One day he said, I am having too much of vision loss and I am having problem, madam. And we repeated the visual fields and this was the scenario. You can see there was a right defect and there was a left defect and this was the inferior arcuate scotoma which patient already had. So we can see that this particular visual field is following the vertical meridian. And we can see there is a kind of homonymous hemianopia in both parts of the visual field. So even if patient is glaucomatous, that doesn't mean that he might not have any neurological problem. So whenever you have a field defect with vertical meridian, don't think about progression. It can be neurological. And we did the imaging. There was a pineal gland carcinoma, which was then further taken up by neurosurgeon. Now coming to another very important thing like media opacities, cataract, as I said, once you remove the cataract after surgery, you can see there is improvement in the visual field. Now here it was with cataract, you can see the total deviation plot which is completely blind, and here you can see the total deviation plot has improved after cataract surgery. So again that means you need to re-establish the baseline visual fields for this particular patient to assess the progression. Now this patient was another interesting case who was following with us and he was non-glaucomatous and but there was a family history of glaucoma. So he was getting his visual fields and although discs were around 0.6, not too much of cupping and there was no notch, etc. Now one day he came with this kind of visual field and so sudden appearance of any scotoma should actually raise your tentacles, you raise your eyebrows that this is not progression, this has to be something else. So we dilated the patient and what we found was there was a large BRVO in this particular patient. The thing is that always examine the fundus whenever you are suspecting something more than simple progression.
Can we wind up?
Yeah, sure. So this was retinitis pigmentosa. There can be artifacts. So the take-home message is that timely detection of progression is very, very crucial because you have to modify your treatment. But always use your clinical judgment and always correlate with your fundus finding. Thank you so much for your kind attention.
Thank you, Dr. Shalini, for those detailed explanation of the challenges in interpretation of visual fields. So we'll move on to the next talk by Dr. Shikha Gupta. She will be speaking on tools to assess progression on imaging devices.
Thank you, ma'am, for the kind introduction. So we have heard about the perimetry devices and all of us are quite familiar with the perimetry. I'll be talking about certain newer devices like the HRT and the OCT. So these instruments come in handy for first-time examination, for example, in pre-perimetric glaucomas. And they're also very handy when we need to follow them up, the patients up, to detect progression, early progression. So when we compare these newer devices with the perimetry, they should always be interpreted in the context of clinical examination and visual field testing, like we have already heard from Dr. Shalini. Patient cooperation is not that important in these devices, as in perimetry, it takes a longer time to examine. We're not looking at the optic nerve, and the patient should be able to understand, and that is why there's a long learning curve, the examples of which we have seen. But in these devices, you just have to scan the optic nerve, and then the software is automated. That leads to initial good assessment of the progression. It is especially useful for the borderline pediatric patients who are like 7-8 years and who can sit upright for an examination, and that can help you detect the progression earlier. And the specificity ranges from 80 to 95%. So similar to perimetry, the progression analysis of glaucoma in these newer devices is also event-based and trend-based. Event-based when we find certain event on follow-up, and trend-based is the linear regression analysis, which can tell us the exact rate in these patients. So coming on to the HRT, which is based on the principle of confocal scanning laser ophthalmoscopy. So there are 3 versions that are available to us. The main versions that was used clinically is HRT2. I'll be showing you certain examples. And then HRT3, which is the latest version, which was launched in 2008. So the problem with HRT2 was a manual contour drawing was required by an optometrist around the optic nerve. So this drawing, if wrong, it could lead to misinterpretation. For example, in this patient, we can see that the contour drawing is shifted to the left side, as a result of which the Moorfield's regression analysis is giving you borderline examination. Other than that, the HRT started with the use of Moorfield's regression analysis. I'll be showing you certain examples where it could compare the optic disc into 6 sectors, 1, 2, 3, 4, 5, 6, and compare these sectors with the database of normal patients. The other problem was with the HRT2 was it took normative database of only 112 Caucasian eyes. So it was limited in its ethnicity, and the database was very less in pool, and therefore it was not so good. This is how the HRT2 gives results. So it gives you a lot of stereometric parameters of the disc, the cup, and other parameters like the RNFL. So this is how it looks like. It's the contour line around the optic nerve. The red area indicates the cup. The blue area is the sloping RNFL, and the green area is the rim here. This is the follow-up examination. This is in 2015, and we can see this is in 2020. And it can actually, this is the comparison with the normal database in the patient, where the red is abnormally different from the normal population. It can be low or high. So suppose cup volume would increase in progression, and the rim volume will decrease in progression. And this is the comparison with this data. So in this, it's almost remained stable, and only this parameter, that is the maximum contour depression, has changed over time. So this is how the Moorfield regression analysis is done. It will compare these sectors with the normal population. If it lies in the lower 99.9%, if it is the 95%, it gives you a tick. If it is between the 95 to 99%, it will give you a exclamation mark in yellow color. And if it is below 99.9%, that is less than 0.1% of the normal population could have that kind of a statistics, it labels it as abnormal or outside the normal range. However, in this patient, we can see that all of the parameters have remained stable over time, over 6 years. So the advantage of HRT3 when it was introduced was that there was no manual contour line drawing which was required. That also was given by the computer itself. And the number of participants in the normal database increased, including it also recruited 100 Indian eyes. So it corroborates with our data also. Other than MRA, it gives glaucoma probability score, which helps us tell whether the patient has glaucoma or not. This is how the glaucoma probability score looks. So without the contour line, the computer is calculating whether it is falling outside the normal range or the border line, which is all yellow in color. Basically, it gives you rim parameters and the cup parameters and the RNFL parameters. So progression on HRT, first thing, it has to be corroborated with progression on perimetry. Other than that, it gives you topographic change analysis. This is an event-based analysis that we have been looking at. It compares the topographic values of different parameters in pixels, which is 4 into 4 pixels. It also gives a trend analysis, which is the stereometric progression graph that HRT gives us. If there is a dip of more than 0.2 units in any of the parameters that we see, it indicates there is a global declining trend. And if both of them show progression, it is definite progression. So this is how the images look like. This is the reflectance image, and this is the topography image. This is the probability map that the computer draws, and this is the significance map. This is what we are actually looking at. So we can see that there is slight dip in the rim, inferior rim of this optic disc over time. Oh, this is over almost like 10 years. Red indicates there is thinning, and green indicates there is thickening. So it shows that the red area is increased, but is it actually significant? So this is showing that this is significant, and this is the topographic change analysis, and this is the stereometric graph. It is also corroborating that yes, there has been a significant change. One box is like 0.2 decibels, and if there is increase in the slope of this line, it indicates definite progression. The left eye was more or less stable, but the right eye showed progression. That was also shown by the color coding in the topographic change analysis. So other than it can give you global stereometric parameters, inferior, superior, and temporal and nasal. So it can actually tell you which area is changing over time. So we did this paper in which we actually looked at only the HRT as a progression parameter, because these are all young patients, juvenile open-angle glaucoma patients. The advantage of HRT or all these newer devices is that it also tells us what is happening to the disc over time. So it is giving us an optic disc image, and sometimes we also see that optic disc is changing. Sometimes even the size changes in these patients because of the change in refractive error. For example, myopia may change in these group. So sometimes the disc may become more tilted with myopia. So it does give you additional information other than the perimetry. Now coming to OCT, I think most of us have OCT in our clinical practice, and it is important to know about how it can help us in detecting progression. So it gives you peripapillary retinal nerve fiber layer thickness, which is global as well as sectoral levels, and it can help us in monitoring progression. However, sometimes when the RNFL really reaches the value of 0 in advanced glaucomas, it may be useful to know about the ganglion cell analysis in the macula, or the other things like perimetry can also help in those cases. So this is how the OCT printout, is the normal OCT printout looks like. This is the multicolored image. This is the OCT image. And this is the TSNIT graph. This is a double hump, asymmetric double hump graph, where the green indicates that it lies in the normal range, more than 95% of the patients will be like that. Yellow is borderline again, and the red is the red flag sign that it is abnormal and going beyond what is expected in less than 0.1% of the normal population. It also gives us the sectoral analysis, just like the MRA that we just saw. And it can also tell us the asymmetry between the two eyes. This is the OU RNFL graph, and we can see that there may be asymmetry, which is showing. So this is the event analysis. In this, unlike perimetry, only 2 examinations will give us yellow or red. So it may not be that specific as compared to perimetry. But in trend analysis, it considers more OCT images. So as a clinician, we have to be wary that it is just the second examination and gives us yellow thing. So we have to really go back, look at the fundus or the perimetry reports, whatever is available to us. So other than this is spectralis OCT imaging, other than the RNFL thickness, we can also compare the minimum rim width in the patients. This is how it looks like. Again, yellow is borderline and red is abnormal. So there are certain parameters that we must be knowing. As is seen in perimetry, even OCT, RNFL thickness decreases at a normal rate, and we should know about that rate. Anything more than 0.1, anything more than 1 microns per year is abnormal. And anything more than 2 microns per year is catastrophic progression that we must treat immediately by surgical intervention. So if there is a decrease in RNF thickness of more than 5 microns globally, it is definitely progression. And in any one sector by more than 7 to 8 microns, it is definitely progression again. And when we compare between the two eyes, a difference of more than 9 microns is indicative of early glaucomatous damage. So we must also corroborate these imaging with the visual fields, and there is a nomogram, which is the broken stick model, that in pre-perimetric and early stage glaucoma, if the RNFL thickness on OCT is more than 83 microns but less than 100 microns, it's most likely early glaucoma. And if in advanced glaucoma, the RNFL would be less than 55 microns. That corroborates to almost like MD of more than -10 decibels. So it is an indication that we must know that OCT can also predict how severe or advanced the glaucoma is. So this is progression. This is the event-based analysis, and this is a trend-based analysis similar to what we have seen in perimetry. And we can see on follow, this is 2017, this is 2020, that various areas have come up as red, again suggesting that there is a possible progression. And this trend analysis will require much more OCT images, and a downward graph is indicative. This is mean. This is the MRW graph, which is not this is RNFL, this is MRW. So both of these will indicate that there is a progression. However, in certain scenarios, we may not be able to look at the RNFL thickness, peripapillary RNFL thickness, for example, in disc colobomas, in tilted disc, in high myopes, where there is a lot of peripapillary atrophy around the disc. So, but if we want to rely on OCT, we can look at the macular GCC in those cases. So this is the macular GCC progression over time of the right eye and the left eye of the same patient. So since macula represents more than 50% of the retinal ganglion cells, a combination of RNFL, GCL, IPL, it can all be useful predictor for early progression. Another indicator could be BMO, MRW, this. But however, again, we should be wary of using macular GCC scans in macular problems like DME, ARMD, or ERM problems. And again, there is a normal loss at the macula at the rate of 0.25 microns per year. So what we have recently published another way how to interpret the macular GCC in analyzing progression. From our center. So this is the right eye, which this is the central macular thickness, and we can see that it's almost stable. So this is how bull's eye, you can look at the red indicates thicker. This is opposite of what is seen in RNFL. Red color is normal in this, and green color is slightly thinner, and blue is the thinnest. So here what we see that there's a Siegel's kind of a defect here coming up where the red is not there. And blue area has replaced the red area. And when we look at the progression in terms of quantitative measures, we see a Siegel's scotoma like a picture. So this indicates that there is a change and it is progressing in the left eye. So conclusions, the newer devices may be very, very helpful, especially in also looking at the structure of the disc or the macula. And they may help us in preceding the diagnosis of progression compared to perimetry by 3 to 4 years. So they have great utility, consistent results, but as a clinician, we must be wary that we use them in tandem with either perimetry or the optic nerve analysis clinically. Thank you very much, and any questions I welcome.
Thank you, Dr. Shika, for those wonderful insights into assessment of progression structurally. Now we shall see the pitfalls in interpretation of structural progression by Dr. Geeta Behra. Over to you.
A very good evening. We'll get on with it quickly in the interest of time. So I will be speaking a little bit on the problems with assessing progression on the imaging devices. So these are the 3 imaging devices which we have, and I will be basically focusing on the OCT, which is the most commonly used device. So the problems with assessing progression on OCT is mainly due to these factors. It's either the floor effect, which is seen in advanced glaucoma, aging, that is RNFL loss at a rate of 0.3 to 0.5% per year, measurement variability, which is device related to the image quality, decentration error, segmentation error or clipping error, presence of local defects that can be easily missed, and cataract development. So floor effect pertains to the point at which no further structural loss can be detected. This is basically seen in advanced glaucoma, and it has to be remembered that the RNFL flows much earlier than the GCIPL. So the average floors that are estimated are 105 microns for the BMO, 38 microns for the GCIPLT, and 38 for the CPRNFL. But please remember that the CPRNFL floors much earlier than the GCIPL. So if in floor effect in early to moderate glaucomas, progressive thinning of the RNFL is measured by imaging is very useful to judge progression, but it has very limited utility in advanced glaucoma. So in advanced glaucoma, progression can be better assessed by macular measures and imaging, that is the GCIPLT, serial visual fields, or combined analysis of both. This has also been proved, and this is a particular study which showed that in advanced glaucoma, more GCIPL tissue remains above the measurement floor compared to other measurements, suggesting that GCIPL thickness is a better candidate for detecting progression. This is just a case I wanted to illustrate. As you can see here, the average RNFL thickness is 52 and 55 microns, which is almost completely floored, whereas if you look at the if you look at the GCIPLT, you still have 65 and 67 microns. So you can follow up this patient. You can look for progression using the GCIPLT. All right. The other option is to do 10-2 visual field testing or to do a macular field. Then the effect of aging. Now, retinal nerve fiber layer thickness loss is at a rate of 0.3 to 0.5% per year, particularly beyond the age of 40 years. Now, it has been seen that the average loss is about 0.5 micron per year beyond the age of 40 years, with the sector-wise loss being even greater, almost 1 micron per year in the superior and the inferior RNFL. And this affects the GCIPLT more than the circumpapillary retinal nerve fiber layer thickness. So this should be kept in mind when assessing progression in a serial analysis of OCTs. Because of the effect of aging, it is now suggested that we use age-adjusted RNFL progression analysis, but unfortunately, this is not there currently in any of the devices. This is in development. Now, the next part is measurement variability. Image quality is a very important source of error. Just to illustrate a case in point, if you see, these are all the image quality of a particular patient done on the same day. And with the variation in the quality score, there's a very large variation in the average RNFL thickness. The baseline was about 93 microns, and the progression drop, that is the actual drop, is about 88 microns. But if we had not repeated it based on the quality score, we would have been stuck at 79 microns. We would have overestimated the progression greatly if we had not looked at the quality score of the patient. Now, so this has also been proved very well that this is a significant source of error even when the SSI values are within the manufacturer recommended limit. So even if the SSI is better than manufacturer recommended limit, it is still a good idea to look at the quality score when comparing it with the previous OCT. Now, measurement variability can also be due to decentration errors. Now, decentration errors are a circle scan error of 0.1 mm can lead to a 2 micron error in the average RNFL thickness. Now, this is huge because the guideline for suspecting progression is 2 microns. But if your scan circle is decentered by even 0.1 mm, you're making an erroneous diagnosis. Again, just to again, another case in point, please look at these 2 scans. This patient, as you can see in the left, in the left map, there is a very large decentration, and the average RNFL thickness is about 79 microns. And when you look at the other map with 85 microns, which is the well-centered circle. The only machine which actually overcomes the decentration error is the Spectralis ST-OCT. It has a dual beam scanning system which completely eliminates the scan circle problem. The other devices, unfortunately, do not have this technology. So the another source of error is segmentation error. So what is segmentation? Segmentation is the delineation of the various layers. So if there's an error in the segmentation, that is if the segmentation is not done properly, for example, in this particular area, the segmentation line is above where actually the RNFL should be. So this will be interpreted as a relative progression here. Similarly, if the segmentation line is going above the area, this will be erroneously reported as being a better scan, but actually this is not the case. So one has to look at the actual scans here. Similarly, there's another very important source of error, which is called a clipping error. If the OCT device is too close to the patient's eye, then part of the scan is inverted and completely clipped out from the analysis. So this area is completely gone. And this shows, and on the progression and the analysis will show that there is a significant progression here as compared to the baseline. Please note that the gray line is the baseline and the black one is the current field. Local defects, again, are very, very commonly missed because local defects generally get averaged in the global metric, that is in the average RNFL scores or the global metric scores that are given. Local defect gets averaged out and they get missed. So again, it's very important to look at the actual segment. So this is the baseline, which is showing, in which one can see the RNFL thickness. And this is the follow-up where actually there's a drop, and that drop is seen very well in the double hump. It's in the graph, TSNIT graph. But this will get missed out when you look at the global average. Again, this is again found to be a very important source of error, and so it is recommended that it should be a standard protocol for detecting glaucomatous progression. Cataract can also cause significant underestimation of the RNFL, much greater than what can be accounted for by the poorer quality score. As you can see here, the quality score between the two imaging time points is 6 out of 10 and 8 out of 10. So the quality score, there's about a signal strength difference of only 2. But if you look at the RNFL score, it's about almost 13 micron difference. So this can easily be misinterpreted as a progression, but after doing the cataract surgery, you see it's almost back to normal. And what you see in the other eye may also be actually due to the cataract and not due to any glaucomatous problem. Again, if a glaucoma patient actually develops cataract, this may be misinterpreted as progression, and only after the surgery is done, the baseline has to be reestablished. This cataract actually affects the GCIPLT far more than the circumpapillary RNFL. Again, if you see, 7 out of 10 is the signal strength here, 9 out of 10 is the signal strength here, but the average thickness difference 56 micron and 64 micron. And if you look at the deviation map, you can see the huge difference in the deviation map between both the eyes. Okay. Again, cataract causes significant underestimation of RNFL, both in cirrus and stratus OCTs. So what is the best structure to measure? It is the circumpapillary RNFL and the macular GCIPL. And about 5 micron is the significant change. But if the RNFL floors are lower, then one can use the RNFL BMO as well. And a normalized trend-based analysis, which are not available and are under development, is what is recommended. So what is the future, what is going to come up? I will be very briefly touching upon the HRT and NFL because there is comparatively less data on the progression analysis, and the HRT was extensively covered by Dr. Shikha. So she just showed you these maps, the baseline exam and the subsequent examinations. The trend analysis showing rate of change. Now the two problems with interpreting HRT. One is that it is dependent on an operator drawn contour line. So if this is drawn incorrectly, then you will get an inappropriate interpretation. The current version uses the GPS and other parameters like the cup shape measure, which are independent of the operator drawn contour line. But again, there is no data on its utility to assess progression. That is not known yet. The NFL, the nerve fiber layer analyzer, is has a wonderful progression analysis, GPA, that is a glaucoma progression analysis, which shows both pixel-wise change analysis and also the trend-based analysis. This is affected by cataract progression, unfortunately. This is because the lens is a birefringent structure, so cataract affects the NFL far more than it affects imaging by other devices. Again, there is minimal data on the progression analysis related to this. Thank you very much for the opportunity.
Thank you so much, Dr. Geeta Behra, for such a wonderful and illustrative presentation. And now I would invite Dr. Subhashini K, who is professor and head at DIPMA Pondicherry, to talk about integrating structure function analysis for assessment of glaucoma.
Thank you, Dr. Shalini. So what we had been seeing so far is how to assess the structural and the functional progression. Now we shall see how to integrate this, both the progressions and so this, I will just first tell you about this Garvey-Heath map, based on which all the combined reports and the combined, the integrated thing is based on. So this Garvey-Heath map is actually a spatial map which between the visual fields and the optic nerve head. And you can see here in the small circle at the left bottom, so that represents the optic nerve head, which is divided into 6 sectors. And you can see the 24-2 field and the numbers within those visual field locations, which is represented as circles. So these numbers actually, they correspond to the sectors of the optic nerve head. So some of you might be having this Glaucoma Forum Workplace, so which is a software which combines the HFA, the fundus, as well as the OCT displays. And this is a combined report of the 24-2 field. Here you can see the OCT display is flipped and to correspond to the visual field area. And you can see the superior arcuate defect and corresponding the optic disc, the OCT changes in that particular sector is corresponding. And similarly, you can see the 10-2 and the glaucoma ganglion cell analysis. This combined report again, you can see the corresponding, the defects in the fields which correspond to the OCT changes in the GC-IPL complex. And similar to the combined report, so there is a progression analysis combining this OCT as well as the fields. And this is for the RNFL, and this is for the GC-IPL. So you don't always see progression in both structure and function. Structural damage can precede the functional loss, and functional deterioration can be detected even in the absence of structural damage. So why does this disagreement occur? So this is because of the different algorithms that are employed to assess the change and the variability of the measurements over time, and to the different scales used to assess structure and function. So there is currently no consensus on how to use the information from multiple tests to assess the progression in glaucoma. So there are researchers working on detecting this progression, in combining both the changes on structure as well as function. So Medeiros et al., he developed a combined structure function index to provide a percentage estimate of the retinal ganglion cells. So Medeiros had done this Bayesian statistics joint model. So this integrates the longitudinal information obtained from structural and functional evaluation. That is, longitudinal means that is over a period of time you record all the fields as well as the OCT, and then these information is translated, and you make an inference from both. So the progression on structure influences the result of the function test. And other authors like Hugh et al. Also, they developed the dynamic structure function model that uses both these measurements jointly to monitor the glaucoma changes. So the advantage of this dynamic structure function model was to give importance to both structure and function, regardless of disease severity. and it makes no assumptions about the relationship between structure and function, nor does it make assumptions about whether change should be identified first in structure or function. And for assessing rate of progression, generally the standard approach is by the ordinary least squares regression. This is a standard approach. So this one study compared the standard approach to the Bayesian joint regression model, and they found that this produces more accurate and precise estimates of the slope of change compared to the conventional method. So basically, as a clinician, whenever there is a progression in structure, but there is no progression in function or vice versa, so the clinician is confused and will not be able to take a correct decision whether to start treatment or step up the treatment. So the integration of the structure and function will help a lot, and still work continues on this integration. Researchers are working on identifying the most sensitive combination of structure functional parameters for early detection of progression, and they are even working on more than 2 parameters jointly, and also to use patient information like the intraocular pressure that is also taken into account while predicting the progression. And the status and the rate of progression in one eye could also be used to modulate the detection of progression in the fellow eye. So in summary, current efforts, they focus on optimizing the various models to identify progression, and this will in fact help us to reduce the time for detection and prevent blindness from glaucoma. Thank you.
Thank you, Dr. Subhashini, for wonderfully summarizing our instruction course on structure and function progression in structural and functional tests for glaucoma.
Thank you all for sitting through this IC, and I know it's close to tea time and you all must be really tired. So thank you for being here. Thank you.
Thank you so much. Thank you.
I would like to thank all the co-instructors, and we can take a snap.
Take a picture, please.